Let's take a quick look at drug mineral precipitation and how it affects our catheters. Precipitation happens when a drug, which is more soluble in an acidic or alkaline state, is given with a solution that doesn't support optimal solubility conditions. This leads to insoluble salts or drug clumps forming inside the catheter, which can block the flow. Causes of precipitation: formation of insoluble salts, for example, calcium phosphate combinations; alteration in drug pH, for example, drugs like phenytoin; concentrations exceeding saturation solubility; use of vehicles to improve solubility; lipid residue left behind from certain solutions. Clearing agents. If you suspect precipitation, here are a few agents to help clear the blockage. Zero point 0.1 Normal solution. Hydrochloric acid for calcium phosphate or acidic drug precipitates. Instill and let dwell for 20 minutes. Repeat if needed. Sodium bicarbonate, 1 milliequivalent per milliliter. For alkaline drug precipitates like phenytoin. Instill and let dwell for 20 minutes. Repeat once. 70% ethanol. For lipid occlusions, instill and let dwell for 1 to 2 hours. Repeat if needed. Intervention. If you notice precipitation after a recent change in infusions, review the history and consider removing or replacing the catheter if necessary. Using a clearing agent carefully, following guidelines to assess the risks and benefits. Prevention. To prevent precipitation, assess medication compatibility before administration. Flush I to V lines before and after drug administration. Regularly inspect fourth tubing for precipitates. Filter TPN solutions and avoid 3-in-1 mixtures. Consider using double lumen catheters for infants to separate incompatible drugs. By following these practices, we can reduce the risk of precipitation and maintain catheter patency. Another complication related to PICC lines and lipid infusions is fungus-related occlusion, specifically caused by the organism Malassezia furfur. Fungus-related occlusion, Malassezia furfur. Cause. This type of occlusion is caused by the presence of the Malassezia furfur organism, which can thrive in lipid-rich environments created during lipid infusions. The organism can colonize IV tubing and catheters, leading to fungal growth that contributes to occlusion. Prevention. Aseptic technique. Always maintain a meticulous aseptic technique when handling the PICC line, especially during the preparation and administration of lipid infusions. Monitor catheter and IV lines. Regularly inspect for signs of infection or occlusion, especially when administering lipid solutions. Intervention. Remove the catheter. If fungal occlusion is suspected, removal of the catheter is necessary to prevent further complications and infection spread. Treat the infection. Antifungal treatment should be initiated based on the healthcare provider's guidance. Common antifungal agents may include those targeting fungal species like Malassezia furfur. This fungal occlusion is a lesser-known but serious complication, and awareness of this risk can help improve prevention and treatment strategies for patients on lipid infusions via PICC lines. Thrombus formation in PICC lines. What is thrombus formation? As a PICC nurse, I have seen at least few cases over the years and managed to remove the clot to able to continue the therapy. Catheter occlusions often occur due to fibrin accumulation or clot formation, which can develop within 24 hours after insertion. Early signs include pump occlusion alarms, difficulty flushing, or trouble withdrawing from the catheter. Symptoms of thrombus formation. Symptoms depend on the location of the PICC insertion site. Common signs include edema above or below the insertion site, pain along the vein's path, and shoulder discomfort. A thrombus in the vena cava may hinder blood flow back to the heart, causing collateral circulation and upper body edema. Types of thrombus: intraluminal, blood buildup inside the catheter lumen; Mural. Fibrin from the vessel wall attaches to fibrin on the catheter surface. Fibrin tail. Protrusion of fibrin, blood cells, and platelets at the catheter tip, which can obstruct during withdrawal. Fibrin sheath. Accumulation of fibrin that covers the catheter tip and shaft. Causes of thrombus formation. Clot formation within the vein or catheter or both. Vessel wall damage or changes in integrity, use of stiff or large catheters in small veins, rapid or forceful insertion and use of guide wires, catheter tip movement or suboptimal tip placement. Prevention strategies: regularly assess catheter function, ensure meticulous flushing with positive pressure and turbulence to prevent clotting. Consider using heparinized infusates to prevent thrombus at the catheter tip. Intervention. If occlusion occurs, thrombolytic agents such as TPA may be considered to restore catheter patency. These measures help manage and reduce the risk of thrombus-related complications in PICC lines. Post-insertion complications, phlebitis and related complications. Mechanical phlebitis most commonly occurs within the first 3 to 7 days following catheter insertion, but can develop at any time while the catheter is indwelling. Infectious phlebitis, the least common type, often a result of untreated mechanical phlebitis. Chemical phlebitis, not typically seen in properly functioning PICC with the tip in the vena cava. More likely to occur with catheter tips outside the vena cava, such as in the midline, develops rapidly, usually within 2 hours after infusing the offending medication or solution. Cellulitis and thrombosis can occur as a complication of phlebitis, requiring prompt intervention. Prevention: regular assessment of catheter function, meticulous flushing with positive pressure and turbulence. Use heparinized infusates to prevent tip thrombus. Intervention: consider thrombolytic agents such as TPA to restore catheter patency. Catheter migration is a complication that may go unnoticed initially and is often only detected during routine imaging. However, clinical signs can emerge depending on the new location of the catheter tip. You might notice difficulty with flushing or withdrawing from the catheter, or the infusion pump might signal an occlusion alarm. In infants, particularly those with arm insertions, you may observe pain cues such as irritability or physical signs like edema and erythema around the shoulder, neck, or arm. In more severe cases, catheter migration may result in perforation or erosion of a central vein. This can lead to serious complications such as pleural effusion, pericardial effusion, or dysrhythmias, especially if the catheter tip has moved out of the vena cava. Catheter damage is another concern, often signaled by leaking at the insertion site or from the external tubing. If you notice fluid pooling under the dressing, it could indicate that the catheter has been severed. In such cases, there's also a risk of catheter embolism. Infants may show signs of respiratory distress or cardiac irregularities, both of which require immediate attention. Prompt recognition and intervention are critical in preventing these complications from progressing and compromising the infant's clinical condition.